Welcome back to the Deep Dive. Today we're digging into the latest edition of Bailey's surgery, focusing on something pretty common, but, well, often surprisingly painful.
That's right. We're talking about the epigastric hernia.
Or EH for short. It's one of those things surgeons encounter frequently, but there's this interesting disconnect, isn't there? A small defect, often tiny, but it can cause really significant pain.
Absolutely. And that's often misunderstood, even among clinicians sometimes. People hear hernia and they picture something quite large, maybe involving the bowel, something you can push back in easily.
Yeah.
But the EH really flips those expectations. It's often small, feels quite firm, maybe doesn't reduce. And yeah, the pain can be intense. So if you're gearing up for clinicals or just interested in the nitty-gritty of surgical anatomy, this is a really key one to understand.
Okay, so using Bailey's as our foundation, let's unpack this, our mission today. Define the EH, really get into why this small thing hurts so much, and cover the modern approach to fixing it, including some important pitfalls to watch out for.
Sounds good. And the definition really starts with where it happens. An epigastric hernia is a protrusion, a bulge, through a weakness specifically in the fascia of the anterior abdominal wall.
But not just anywhere on the front wall, right?
No, critically, it's only in the linea alba.
The linea alba, that's that central line, the sort of fibrous seam running down the middle.
Exactly. Right down the middle. From the tip of your breastbone, the xiphoid process, down towards the navel, the umbilicus.
Why there? Why is that central seam the weak spot? You'd almost think it would be stronger, holding everything together.
It's a bit of an irony, isn't it? You've got these big, strong rectus muscles on either side, the six-pack muscles, but the linea alba itself is this fibrous band, a raphe, where the connective tissues, the aponeuroses from the side muscles weave together.
Like a seam in fabric.
That's a great analogy. And like a seam, it's inherently less vascular, less blood supply, and it takes a lot of sideways or transverse stress. Think about lifting something heavy or chronic coughing.
All that pressure pushes outwards.
Right. And it puts strain on that midline seam. So the defect isn't really a muscle tear. It's more like a split or separation within that fiber seam.
Okay.
And Bailey's is quite clear here. The defect usually starts as a small, sort of elliptical split running sideways across that vertical midline.
And tiny, you mentioned.
Often really small, yeah. Frequently less than a centimeter across, which seems counterintuitive when we talk about the pain level.
Which brings us to the next surprise.
Yeah.
What's actually poking through that tiny hole? If it's not usually bowel.
Exactly. Unlike inguinal hernias or larger umbilical hernias, the EH, especially when it's small, typically contains extraperitoneal fat.
Extraperitoneal, meaning outside the main abdominal cavity lining.
Precisely. It's the layer of fat that sits just outside the peritoneum between that lining and the abdominal wall muscles themselves. And when there's pressure, this fat finds the path of least resistance.
Which is that little split in the linea alba.
Right, through that defect.
So, okay, we have this small split in the central seam, and it's just fat pushing through. Why on earth does it hurt so disproportionately much? Enough to often need surgery.
Now we're at the core of it. This is the crucial pathophysiology. It's not about what's bulging, but how it's bulging and getting trapped. We need to talk about something called the mushroom effect and the rigid neck problem.
Okay, let's break that down. The mushroom effect. What's happening there anatomically?
So imagine that small plug of extraperitoneal fat being forced through this tight, inflexible little hole in the fascia, the linea alba.
Right.
That hole, the defect, acts like a rigid ring. Once the fat squeezes through, it can't easily go back, and it starts to spread out in the space just under the skin, the subcutaneous layer.
Ah, so the fat outside the hole balloons out.
Exactly. It forms this sort of mushroom shape. The narrow stalk is the fat passing through the tight fascial defect, and the cap is the fat spreading out under the skin.
Yeah, I can picture that. And you mentioned it often starts without a peritoneal sac.
Yes, particularly when they're small. They arise in these sort of interstitial layers first. There's no interlining pouch initially, unlike many other hernias. That peritoneal sac might get pulled in later if the hernia gets much bigger, but often it's just this bare fat poking through.
This probably makes it feel quite firm right from the start.
It does. That and the fact it gets trapped. Which leads us to the rigid neck problem. This is where the pain mechanism really kicks in.
So why is that small, rigid hole, the neck of the mushroom stalk, so problematic for the fat trapped inside?
Because it acts like a constricting band. It pinches the base of that fatty protrusion. The fat gets squeezed through, but then it gets stuck. It becomes irreducible. You can't push it back in.
Okay.
But the real issue is circulatory. It causes a localized squeeze.
Like cutting off the blood supply.
Not quite the arterial supply initially, but definitely the venous drainage. Think about it. Veins are low-pressure vessels. That tight fascial ring immediately compresses the veins, draining the trapped fat. Arterial blood might still get in, but the venous blood can't get out easily.
So the fat just swells up. Like inflating a balloon you can't deflate.
Exactly. It gets congested, engorged with trapped blood. The pressure inside that mushroom cap rises dramatically.
That's the source of the pain.
That's it. That tension and swelling stretches the tissues and directly irritates the local nerve endings within and around that fat. The source material calls this a partial strangulation of the fat.
Partial strangulation. So not like bowel strangulation, which is a surgical emergency.
Correct. It's not usually immediately life-threatening because it's just fat, but the process, the tissue ischemia, the swelling, the tension, generates intense, localized, and often constant pain or tenderness.
Which makes sense why patients seek help, even if the lump itself is tiny. It's this persistent, nagging, sometimes severe ache.
Absolutely. That painful paradox, small defect, big pain, is all down to this mechanism. Fat getting trapped and choked by that rigid little neck in the linea alba.
Okay, moving on to the clinical side. Who typically gets these? Is there a common patient profile?
It's interesting. There's sort of a bimodal distribution. You often see it in otherwise fit, healthy, sometimes quite muscular men, maybe middle-aged, people doing strenuous activities, lifting.
Putting repeated pressure on that midline.
Exactly. But then you also see it commonly in older individuals, both men and women, particularly those who might be overweight, and very frequently in women who've had multiple pregnancies.
Ah, the pregnancy stretching and weakening that whole linea alba area.
Precisely. It makes the entire structure more vulnerable to these little splits.
And when a patient comes in, how does it usually present? What are they feeling, and what do you find on examination?
Typically, the patient points to a very specific spot on their midline, somewhere between the breastbone and belly button. They'll describe a lump, maybe small, but the key feature is tenderness. Often exquisite tenderness right over the lump.
And because of that rigid neck we discussed.
It's almost always non-reducible. You try to gently push it back in and it just won't go. It feels firm, maybe rubbery, and the pain often gets worse with anything that increases abdominal pressure, coughing, straining, even just sitting up from lying down.
That sounds like it could easily be mistaken for something else. A small, firm, non-reducible lump.
Absolutely. And this is a major diagnostic pitfall highlighted in the sources. It can strongly mimic a lipoma, just a benign lump of fat under the skin.
Right. How do you tell the difference?
The key is often the location of the tenderness. With an EH, the tenderness is usually most intense right at the base, at the fascial defect, the stalk of the mushroom, if you like. A simple lipoma might be non-tender or only vaguely uncomfortable. And the EH pain is often much more severe and activity-related.
Okay. What about the classic hernia sign, the cough impulse? Can you feel it bulge when the patient coughs?
Sometimes yes, sometimes no. And that can really muddy the waters diagnostically. If that neck is so tight that the fat is completely jammed in there, there's no room for anything more to push out when they cough.
So no cough impulse might actually point towards a tightly incarcerated EH rather than ruling it out.
Exactly. The absence of a cough impulse definitely doesn't exclude an EH, especially a symptomatic one. It might just mean the neck is very narrow and the contents are well and truly stuck.
Now, you mentioned pitfalls. Bailey's apparently has a pretty stern warning about recurrence after surgery.
Yes, this is critical. The text emphasizes that the most common reason for what looks like a recurrence the patient comes back months later with another lump nearby isn't actually the original repair failing.
It's something else.
It's often the surgeon having missed a second, smaller defect nearby at the time of the first operation. A sibling hernia, if you will.
Because that whole linea alba is potentially weak.
Precisely. It's one continuous fascial structure. If you have a split causing symptoms at one point, there's a decent chance there might be another tiny asymptomatic split just an inch above or below it.
Which the surgeon might not have noticed or looked for.
Right. They fix the obvious symptomatic one, but leave the little occult one behind. Then, over time, that second one enlarges and becomes symptomatic, and the patient thinks, my hernia came back.
So the lesson is, during the operation, you have to assess more than just the obvious lump?
You have to meticulously examine the entire relevant length of the linea alba. Whether you're doing an open repair or laparoscopically, you need to actively look for and address any other potential weaknesses along that midline strip to prevent this kind of pseudo-recurrence.
Okay, so management. Given that it's usually fat and not immediately life-threatening like trapped bowel, when do you actually need to operate?
The main driver is symptoms. If you have a small to moderate EH just containing fat, and it's not causing the patient significant pain or discomfort, you might not need to rush into surgery. Observation can be an option.
But if it's painful?
If it's symptomatic, causing that persistent pain, interfering with activities, or it's irreducible and tender, then yes, surgery is usually recommended to relieve the symptoms and prevent potential worsening.
And the exception?
The big exception is if, very rarely, an EH does contain bowel. That's an immediate surgical indication because the risk of bowel strangulation with that tight neck is extremely high. That needs fixing regently.
It's interesting. The source mentions they can sometimes disappear on their own.
Yeah, it's mentioned for very small ones. The thinking is that the fat trapped in that tight neck might actually undergo infarction, basically. The blood supply gets cut off completely, the fat tissue dies, and the body eventually just absorbs it.
A rather grim natural resolution.
A bit, yes. But it highlights how severe the constriction can be. But for most symptomatic EHs, surgery is the way forward.
Let's talk about the standard open repair first. How's that typically done?
It's usually quite straightforward. The surgeon makes an incision, often a small vertical or transverse one, directly over the lump.
Find the mushroom.
Find the mushroom, expose the defect in the linea alba, and then deal with the contents, that protruding plug of extraperitoneal fat.
Do you push it back in?
Often, no. Because that fat is usually already congested, maybe a bit ischemic or damaged from being squeezed, it's often better to simply excise it, cut it out. Trying to stuff damaged tissue back isn't ideal.
Is there anything tricky about cutting that fat out?
There's one specific caution. That fatty plug often contains a small blood vessel. You need to identify and properly control that vessel, ligate it, or cauterize it before you just cut the fat away. Otherwise, it can retract and bleed into the wound, causing a hematoma or just troublesome bleeding afterwards. So careful handling of the contents is key.
Okay, fat dealt with, vessel secured. How do you close the hole in the fascia?
It depends on the size. For very small defects, maybe less than a centimeter, especially in children, you might just close it with sutures, bringing the edges of the linea alba back together. Usually non-absorbable sutures in adults, maybe absorbable in kids.
But for larger ones, or if there's tension?
Then the standard care increasingly leans towards a tension-free repair, similar to how we approach umbilical hernias. That usually means reinforcing the closure with a piece of surgical mesh.
Okay, mesh reinforcement. Now, what about the minimally invasive option laparoscopy? How does that work for an EH, and are there specific challenges?
Laparoscopic repair is definitely an option, often using techniques similar to an umbilical hernia repair, like placing mesh from the inside IPOM, intraperitoneal onlay mesh. But EHs have a unique anatomical hurdle,
Which are
falciform ligament.
the ligament connecting the liver to the front abdominal wall.
Exactly. It runs right down the midline superiorly, often directly over where these epigastric defects occur. So when you're looking from the inside with the camera, the actual hole in the fascia can be hidden behind this ligament.
So you can't see the defect properly.
Correct, or you can't see its full extent. To do the repair properly laparoscopically, the surgeon usually has to take down or divide part of the falciform ligament to fully expose the edges of the defect.
So you can place the mesh correctly with enough overlap.
Precisely. You need to see the entire circumference of the hole to secure the mesh effectively. If you don't, the repair is likely to fail. So that's an extra step compared to, say, a lower umbilical hernia.
And there's another critical point about the laparoscopic approach related to the fat plug.
Yes, absolutely crucial. You must ensure that trapped extraperitoneal fat, the mushroom cap, is fully dealt with before you place the mesh.
Meaning pulled back inside or removed.
Exactly. It needs to be fully reduced back into the preperitoneal space or excised if necessary. If the surgeon just puts the mesh on the inside over the defect, but leaves that congested fat plug trapped between the mesh and the skin,
The patient still feels a lump.
they're left with a palpable lump and likely ongoing pain or discomfort, even though the fascial hole is technically covered. They'll think the surgery didn't work or they have a complication. So complete reduction or excision of the contents is vital in the laparoscopic approach too.
This brings us nicely to modern guidelines and advancements. You mentioned the trend towards mesh reinforcement. Is that now pretty much standard for EHs unless they're tiny?
Yes, the general shift across all ventral hernia repair, including EH, is heavily towards tension-free mesh reinforcement. For almost any defect in an adult bigger than, say, 1 centimeter, or really any situation where just suturing the edges together would create tension, mesh is now strongly recommended, if not mandated by guidelines.
And are there specific guidelines for EHs?
Yeah, the European Hernia Society, EHS, published updated guidelines for both umbilical and epigastric hernias around 2020, reflecting this consensus. They really emphasize achieving a tension-free repair.
What kind of mesh is preferred? Bailey's apparently showed a picture with polyester, but is that typical?
The general trend now favors large pore synthetic meshes, most commonly polypropylene.
Why large pore?
The idea is that the larger pores allow for better tissue ingrowth. The patient's own cells, fibroblasts, collagen, can integrate into the mesh structure more effectively. This seems to lead to less scar plate formation, less mesh shrinkage or contraction over time.
And maybe less chronic pain.
That's a key goal, yes. The older, heavyweight, small pore meshes were often quite stiff and could sometimes be associated with a higher incidence of chronic discomfort or pain. The modern large pore meshes are generally lighter, more flexible, and seem to integrate better with the body's tissues, potentially reducing that risk.
But if you're doing that laparoscopic IPOM approach, placing mesh inside against the bowel, you can't just use standard polypropylene, right?
Absolutely not. That's a critical safety point.
Uh-huh.
If the mesh is going to be in direct contact with the intestines or other organs inside the abdomen, intraperitoneal placement, you must use a tissue-separating or composite mesh.
What does that mean?
These have a special coating or barrier layer on the side facing the bowel, often made of materials like EPTFE, or an absorbable collagen-based layer that prevents the bowel from sticking to the mesh.
Because standard mesh would cause adhesions.
Severe adhesions, potentially leading to bowel blockages, erosion of the mesh into the bowel wall, or even fistulas down the line. These are serious complications surgeons are increasingly trying to avoid.
Which might be why some surgeons prefer other techniques.
Exactly. There's a growing movement towards placing mesh in planes outside the peritoneal cavity altogether, like behind the rectus muscles, retromuscular, or in the pre-peritoneal space, often using advanced laparoscopic or robotic techniques like ETEP. The goal is to keep the mesh away from the bowel whenever possible.
And finally, circling back to that recurrence issue missing the sibling hernia, how do modern guidelines address that specifically?
They reinforce the principles we discussed. First, ensure adequate mesh overlap. The mesh should extend well beyond the edges of the primary defect several centimeters onto healthy fascia to cover any small nearby weaknesses.
Cover the whole zone of potential weakness.
Precisely. And second, reiterate the need for that meticulous survey. Whether open or laparoscopic, the surgeon has a responsibility to carefully examine the relevant length of the linea alba to identify and address all defects present at the time of surgery. It's about being comprehensive.
Okay, let's try and distill this down. We've covered a lot about this seemingly small hernia. What are the absolute key takeaways for our listeners?
I think there are 4 main points to really lock in about the epigastric hernia.
Go for it.
1, location and nature. It's a midline defect, only in the linea alba fascia, not muscle.
Got it. Midline fascia split.
2, the contents. Primarily contains extraperitoneal fat, especially when small, not usually bowel.
Okay, fat not good.
3, the pain mechanism. That small, rigid defect neck traps the fat, causing partial strangulation, venous congestion, swelling, and that characteristic disproportionate pain. It's the tight neck that's the problem.
Small neck, big pain. Makes sense.
And 4, critical management points. Remember, the falciform ligament can obscure the view laparoscopically. Always ensure complete reduction or excision of the fatty contents. And crucially, always search for and address potential multiple defects along that midline.
Don't miss the sibling hernia.
Don't miss the sibling hernia.
It really highlights how understanding the specific anatomy and the mechanism why it hurts dictates the whole approach, doesn't it? You can't just treat all bulges the same way.
Not at all. The differences between an EH and, say, an inguinal hernia are fundamental to getting the diagnosis and treatment right. Recognizing these nuances is key.
And that final point about recurrence often being a missed second defect. It leaves you thinking, doesn't it?
It really does. It's a powerful reminder, I think, that in surgery and maybe in medicine generally, when you find one problem in a system,
You need to consider the health of the whole system.
Exactly. A single fascial split might just be the most obvious sign that the entire linea alba in that region is under stress and potentially vulnerable. Successful, long-lasting repair isn't just about patching the obvious hole. It's about understanding and reinforcing the entire area at risk.
A fascinating look at a small defect with truly significant implications. Thanks for walking us through the details from Bailey's today.
My pleasure. It's a neat topic.
And thank you all for joining us on the deep dive. We'll catch you next time.